Okay, so we'll go ahead and get started. Welcome everyone to UCSF's Cardiology Grand Rounds. I'm incredibly honored to be able to present today Dr. Rebecca Hahn, who will be speaking to us on interventional imaging. Dr. Hahn is professor of medicine at Columbia University Irving Medical Center in New York and chief scientific officer of the Echo Core Lab at the Cardiovascular Research Foundation. She's the director of interventional echocardiography at the New York Presbyterian Columbia Campus Structural and Valve Center. She has served on the board of directors for the American Society of Echocardiography and is currently a member of the American College of Cardiology Competency Management Committee and Scientific Sessions Planning Committee. She has published over 350 articles and 10 book chapters on echocardiography and valvular heart disease, and has been on the writing committees for 4 American Society of Echocardiography recommendation guidelines and 4 academic research consortium documents. She was the national PI for the SCOUT trial and is the national co-PI for the TRISCEND pivotal trial, looking at transcatheter interventions for tricuspid valve disease. And with that, welcome, Dr. Hahn. I'm excited to hear your talk. If anyone has questions over the course of the talk, please type them into the chat box. Or if you prefer to keep the questions anonymous, you can go ahead and direct message me and I can ask the questions on your behalf at the end. Dr. Hahn.
Great. Thank you so much. Thanks for the invitation to speak. This is obviously a topic near and dear to my heart, and I think we have a lot of new roles for the interventional imager, and it has become its own new subspecialty. These are my disclosures. So today, hopefully, we'll learn about how the field of structural heart disease has really evolved and created the need for structural imagers, and appreciate the role that the imager plays throughout the patient's disease process management, and then review the role of imaging throughout the procedures. Structural heart disease, if you didn't know, is a new term. It's a term that was introduced in 1999 by Dr. Leon at one of the TCT meetings, and was meant to encompass all those non-coronary disease processes that could be treated with transcatheter devices. And then in 2009, he introduced the term interventional echocardiographer to describe the new role that he had for me, and had taken me out of the echo lab and basically placed me into the cath lab. And so I think what we've learned is that the heart team, which is composed of so many different components, obviously all centered on treating the patient, actually must include the cardiac imager. And this is where all the guidelines seem to agree. And so the ACC guidelines clearly state that all patients with severe valve disease should be evaluated by a multidisciplinary team, and that team is going to be defined, obviously, by having imaging personnel that have expertise, not only in echocardiography, but CT and CMR, and how to use each imaging modality effectively. And the European guidelines have the same type of criteria, that to deliver optimal care, you have to have a heart center and a heart team that has a multimodality imager involved in the care. And so one begins to wonder and ask whether or not it really matters whether you have a dedicated heart team and a team that has an imager on it. And we now have at least one study now that's looked at the outcomes based on having a dedicated heart team. And this happens to be a mitral heart team. And this center looked retrospectively at mitral valve disease patients treated by a general heart team, and then obviously development of a dedicated mitral valve heart team. So there's obviously some bias by time, but in general, what they looked at was the outcomes based on whether they were treated by the dedicated heart team versus the general heart team. And that dedicated heart team was composed of a mitral surgeon, an interventionalist, and then an imaging specialist. And so in looking and having that team with its composition, they found that after adjusting for multiple risk factors, the relative risk of mortality for patients with a dedicated heart team was almost 30% lower than for a general heart team. So that if you had a dedicated team that was used to treating patients with specific valvular heart diseases, those patients did better. And that was irrespective of whether or not the team, the dedicated team, recommended surgery or non-intervention. So no surgery or no intervention versus intervention. Indeed, when you looked at patients that took the advice of the heart team versus didn't take the advice of the heart team, there was again a mortality benefit to taking the advice of the heart team, and the implementation of the dedicated heart team, multidisciplinary team, improved the survival of patients with mitral valve disease. And so we now know that throughout the patient's path of care that we need to actually involve the imager in all aspects of patient selection, procedural planning, procedural guidance, and follow-up. And so the new roles that have been defined for the imagers to understand the pathophysiology of the disease, develop the best practices surrounding both pre-procedural and intra-procedural guidance, and then innovation, which we'll show you at the end. And so each of these roles, I'll use a specific valve to try and exemplify, although all the valves we're involved with every single new role. But we're going to start with the aortic valve in understanding the pathophysiology of the disease. So we know that for symptomatic severe aortic stenosis, there is a tremendous undertreatment of those patients. We've known this for a long time. And part of the reason I believe that that is true is that we have a lot of patients that have low flow, low gradient aortic stenosis. And we've been dependent on for a long time on defining the disease based on gradient alone. And that's going to be a problem. So with the low flow, low gradient patients, obviously, they're not going to meet gradient criteria, despite the fact that they could make valve area criteria. And so if we start with D2, then we can see that those the D2 patients are the symptomatic severe low flow, low gradient aortic stenosis patients with low ejection fraction. And it's pretty easy to understand why they might have low gradients. They just don't have the same contractile force as a patient with normal ejection fraction. And so for all the patients, the guidelines recommend that you optimize blood pressure before assessing, which is going to be true whether you have normal flow or low flow, and then use low dose dobutamine in those patients with low ejection fraction. And we'll talk a little bit about calcium score in a minute as well. So when you look at those patients, again, you're looking for patients with low ejection fraction, less than 50%, and you're going to give them dobutamine in order to increase stroke volume and flow. And so you're looking for an increase in stroke volume of 20% to show that there's contractile reserve. And in that setting, if the gradients go up, the valve area stays small, then you have true severe aortic stenosis. If the gradients stay low and the valve area goes up, the opposite, then those patients have pseudo-severe or moderate disease. And typically we've been treating those with medical therapy, but we'll talk about that in a little bit as well. Now, those patients who don't have contractile reserve become a difficult patient population. What do you do? Can you make the diagnosis? And it turns out you can. Using the dobutamine stress test, we then can map out change in valve area with each increase in flow. And even if you don't make the normal flow, and that would be defined as 25 mils per second, then you can still project the valve area out to that flow rate in order to determine whether or not their valve areas are under 1 centimeter squared or not. And so the patient with less contractile reserve, with the yellow dots, if you projected them out, they would actually have moderate aortic stenosis. Whereas a patient in the red who also did not have contractile reserve, when you project out using, again, simple mathematic formulas to look at normal flow, you can see that they remain severely stenotic, and those are patients with true severe aortic stenosis. So the projected valve areas have been well validated. This is a study looking at the TOLPAS multi-center registry of true or pseudo-severe aortic stenosis patients, and clearly the projected valve area correlated well with explanted valve weights, and therefore obviously with the severity of calcium, compared to traditional dobutamine stress indices. And then in addition, it was a predictor of outcomes, and that's the most important thing. So traditional dobutamine stress indices were not, but projected valve area was. So again, we do believe that the projected valve area has a great prognostic significance, and that's what we do when we're doing our dobutamine stress echoes. This is a study that looked again at the fact that the routine measurements of mean gradient and aortic valve area were not predictive of mortality on dobutamine stress, but that projected valve area indeed did predict pseudo-severe from true severe aortic stenosis, and it was highly associated with mortality. So the other method that we have for determining severity is calcium score. And it was found early on that when you looked at patients, that the amount of calcium is determined by the aortic valve calcium load on CT, that you could actually see a relationship between the amount of calcium and the severity of disease. That makes sense. And so Maria and Clavel took a large patient population with low flow and normal flow and determined the cutoffs that would determine severe disease in those patients with traditional criteria for severe aortic stenosis, and found that they would also predict true severe aortic stenosis in patients with low flow, and so could differentiate between moderate and true severe aortic stenosis. And these are the cutoffs that she found. Interestingly enough, they were very different for females and males. So females tend to have less calcium, more fibrosis, and males obviously will calcify. The rate of calcification differs by females. It's a whole different lecture. And it is not based just on the size of the valve. So that's where the aortic valve density comes in. Clearly, the density of calcium is less in females. And so we now have sex-specific thresholds that have been also validated by other groups. So this is Powati looking at, again, sex-specific thresholds for severe aortic stenosis that predict outcomes. And so 3 to 4-fold increase in events when those criteria were met, lower for women than for men. So now we have in our little algorithm the ability to use projected valve area and CT calcium score to determine whether you have true severe aortic stenosis or not. And in addition, just a reminder that the European guidelines are slightly different. They're using slightly higher criteria to measure highly likely, likely, and unlikely to have severe aortic stenosis. If we look at D3, D3 is less easy to understand. This is the symptomatic severe patients with low gradient AS and normal ejection fraction. So this is paradoxical low flow severe aortic stenosis. And the picture that you see here is a classic example of that, because those patients that have severe concentric hypertrophy, again, tend to be more common in females, may also have diastolic dysfunction, which reduces the filling of the left ventricle, and therefore the entire stroke volume of the entire volume of the ventricle is much lower than normal, and therefore the stroke volumes are low in the setting of normal endocardial excursion. In addition, we know that even though you might have normal ejection fraction and endocardial excursion, that the mechanical function of the ventricle is highly dependent on fibrotic changes. And so with more left ventricular concentric or hypertrophy or remodeling, you may end up having more fibrosis, and then mechanical dysfunction occurs as can be detected by strain and other methods. And so those patients may have normal ejection fraction, but low strain. And then patients who are tachycardic, this was a pacing study done by Philippe Pibereau's lab using the patient as their own control, showing that as the heart rate goes up, and this is the patient again as their own control, then their stroke volume goes down. So it makes sense because the cardiac output is what remains the same. We've also had patients, and this is one of ours that was for the Partner 1 trial, who ended up having hypertension when they came in. And so in that setting, in the cath lab, we gave nipride, which can be safely done, obviously, under monitored situations. And you can clearly see that the mean gradient goes up. And so this is a patient that eventually we were able to meet the criteria for the Partner trial. But hypertension is going to reduce the mean gradients across those valves. And then finally, any kind of dysfunction that's going to reduce forward flow may still manifest itself as normal ejection fraction, but low flow. And so this is degenerative mitral stenosis, mitral regurgitation, severe tricuspid regurgitation, all of those obviously associated with very normal left ventricular function. So again, for those patients, the same thing applies. We must optimize blood pressure before assessing. And we don't typically use dobutamine because in the setting of concentric hypertrophy, in particular with restrictive disease, that may be a dangerous proposition. But we do like to use calcium score. And so we can use both of those in order to try and determine if you have severe low flow, low gradient aortic stenosis. And the guidelines would recommend a class 1 recommendation for intervention at that time. The one thing to remind you is that we now also have sex-different differences in cutoffs for stroke volume index. Normally it would be 35 mils per meter squared, but this study clearly showed that there is a difference, and the cutoff for low stroke volume should be 40 mils per meter squared in men, and 30, we maintain 35. In this study, it was 32, but the guidelines in Europe are now suggesting to use 35 for women and 40 for men. Now, what about in those patients with asymptomatic disease? Well, we have a class 1 indication to intervene if the EF is less than 50%, and to intervene at the time of left heart surgery if you have asymptomatic disease. But is 50% the appropriate cutoff? And it turns out that multiple studies now, and this is all based on imaging, show that the ejection fraction of less than 60%. This is a study that shows less than 55%. This is a study that shows less than 60%. All of those patients have worse prognosis than those patients that maintain an ejection fraction of greater than 60%. So 60% is the new, what I would consider the new normal expected ejection fraction for a patient with severe aortic stenosis. And in that setting, a class, the indication to intervene with an EF of less than 60% was given a 2B recommendation. So remember, again, a lot of 2A and 2B recommendations for treating those patients with asymptomatic disease. We mentioned before that fibrosis becomes an important part of mechanical function of the ventricle. And it turns out that by CMR, so again, imaging modalities, we are able to determine whether or not there is diffuse, which is reversible fibrosis, or there is replacement fibrosis, which tends to be irreversible. And when you look at that, you can now determine that those patients, obviously, we want to intervene at a time when you still have reversible fibrosis. And so the algorithm for those patients with asymptomatic disease may be that we intervene when the ejection fraction starts to fall below 60, that we're looking at global longitudinal strain, but also CMR for myocardial abnormalities, including T1 mapping, extracellular volume percents, and obviously late gadolinium enhancement. And that will help us determine when to intervene and not to intervene too late. We do have to remember that, again, there is sex dimorphism in myocardial remodeling. Obviously, women are associated with having more concentric remodeling, despite similar hemodynamics of men and women. They will tend to have more concentric remodeling, and in this study, limited biomarkers or fibrosis, and this is the replacement fibrosis, whereas other studies have clearly shown that women will have more early fibrosis, so we'll have larger ECV fractions, so extracellular volume fractions, which is reversible fibrosis, and compared to men. So something to think about. There are a lot of sex-based differences in the response of the valve and ventricle to stressors. Now, the one other area that is deserving of attention is going to be moderate aortic stenosis. We've got, as we have already discussed, a number of class 1 and class 2 recommendations for severe aortic stenosis. There's actually only one class 2B recommendation for those patients with moderate disease, and that's in those patients undergoing cardiac surgery for other indications. But when we start to look at the data on moderate aortic stenosis, again, based on imaging criteria, then one of the most powerful studies was the NEDA study, the National Echocardiographic Database of Australia study on moderate aortic stenosis, where they found, and this is thousands and thousands of patients now with echocardiograms, that when they looked at long-term follow-up, this is 15 years of follow-up, that there were similar outcomes with severe and moderate aortic stenosis. Now, this finding has been, and again, the curves, line up very early on. It's not that they start to separate late. They're on top of each other starting at year 1. And so lots of studies have gone on to show the same thing, that those with moderate aortic stenosis, and again, it may be how we're defining moderate and severe. Maybe severe is actually 1.2 centimeters squared instead of 1.0. But in any case, many studies now showing that moderate aortic stenosis is associated with a number of concomitant issues, such as ventricular dysfunction, diastolic dysfunction, et cetera, and is indeed associated with higher all-cause and cardiac mortality. Why might that be? Well, it's possible that we're misclassifying, as I implied, that particularly if you rely just on gradient, that you're actually going to have low flow true severe aortic stenosis, and you're calling it moderate because of gradient. It's also possible that at the time of evaluation, it was indeed moderate, but it progresses rapidly to severe. And that has been also shown in a number of cases that rapid progressors are going to have worse outcomes. And we know also that those patients with moderate aortic stenosis may already be starting to have cardiac damage, and that even though their ejection fraction remains 60%, they may already be fibrosed. And then it's obvious that all of these factors suggest that we're intervening too late. And so 3 different trials now ongoing. TAVR Load will finish at the end of this year, not meeting its the patient number that they intended to enroll, but they should have enough to show outcomes. And given what we know to be the poor outcomes associated with moderate aortic stenosis, possibly worse than in some of the randomized trials for severe aortic stenosis, we also have now the Progress trial for the balloon expandable valve and Expand TAVR 2 for the self-expanding valve, all evaluating outcomes associated with intervention or medical therapy in those patients with moderate aortic stenosis. So moving on to mitral valve and then shifting into the pre-procedural planning. This is where pre-procedural imaging is going to play a huge role. And we know from the 2020 expert consensus decision pathway that echo and understanding when to intervene with transcatheter devices has become a major update to our treatment algorithm, as well as the addition of heart failure experts to initiate guideline-directed medical therapy. But right up front with the entire algorithm is going to be the imager. And so the imager is absolutely key to diagnosing severity, etiology, and then determining whether or not they're appropriate for various interventions. And so similar to all other valve diseases, TEE, CMR, CTE even, very important in the diagnosis of mitral regurgitation. So here we have the Carpentier classification with some of the echocardiographic images that might be associated with them. And primary disease, obviously, in the patients that receive transcatheter devices typically are the type 1 disease, which is excessive leaflet motion. So this is the patients with prolapse and flail. And these are the classic patients that come to us with for intervention, a transcatheter intervention. But the guidelines are very clear that at this time for primary disease, those patients must have high or prohibitive surgical risk, that those patients that can get repaired surgically with a 95% rate of estimated rate of repair should get surgical repair. That's the class 1 indication, whereas the class 2A indication is if they feel they can't get surgical repair, then to go ahead and consider transcatheter repair. Obviously, we have trials now ongoing, which are looking at the lower risk patient population to see whether or not there is a mortality benefit to treating a lower surgical risk patient population. But for now, it is high and prohibitive surgical risk in the primary disease. Now, what about secondary disease? Well, there are 2 types of secondary disease. There's the type 1 with normal leaflet motion, and the type 3 with abnormal leaflet motion. So the normal leaflet motion we now know is called atrial functional mitral regurgitation. I think in the past we were always pretty confused as to what this was because we couldn't see prolapse, but we sure saw a lot of regurgitation. And so this is indeed annular dilatation, typically in the setting of atrial fibrillation or HFpEF. And those patients have marked dilatation of the annulus and atrium, therefore having not enough leaflet to cover the annular area. There seem to be 2 morphologies. This is all based on imaging again. The ones with pure annular dilatation, and then the ones that have something called atriogenic leaflet tethering with a posteriorly directed jet. And these are patients that have what's called hamstringing because of the ventricular insertion of the leaflet, the relative insertion to myocardial, to the base of the LV. And so the leaflets get hamstrung and therefore cause regurgitation. The ones that have 3B restricted leaflet motion, predominantly in systole, obviously, are the non-ischemic and ischemic cardiomyopathies. The ischemics tend to be much more symmetric, so the regurgitation is all along the commissural line, whereas the ones that have regional abnormalities, typically inferior wall infarct, are going to have their regurgitation more along the medial side. And so there are some differences to where we might want to do our procedure. Again, the guidelines are very clear. It's a 2A recommendation, and you must have mitral anatomy that is favorable, as well as the other criteria by which the COAPT trial enrolled their patients. So EF of 20 to 50%, and systolic dimension, not diastolic, and systolic dimension of less than 70 millimeters, less than or equal to, and a PASP of less than or equal to 70 millimeters of mercury. So again, favorable anatomy is the key. And so what is that favorable anatomy? Well, when we looked at the Everest trial, they defined the favorable anatomy. And so based on the success of both the Everest and the COAPT trial, which use those same anatomic criteria, we know that there's a number of favorable features depending on where the pathology is, what the mitral valve area is, what the grasping zone is, how big the flail is, and how deep the coaptation depth, how much tethering there is. And those are all favorable. But there are a lot of others since then, because of the volume of clips that we've done in the United States and elsewhere. There are many other predictors of outcomes of the mitral transcatheter edge-to-edge repair devices or TEER devices. And so echocardiographically, obviously, you can look at valve area, the width of the flail, the length of the coaptation depth, and the total annular area. But there are other factors that one might consider, like pulmonary hypertension, the size of the ventricle, and the dysfunction of the left and right ventricles, as well as the presence of tricuspid regurgitation. All of those will indeed predict poorer outcomes. Now, if you just look at the anatomy of the valve, and this was a beautiful classification that was developed by the German Cardiac Society, and not a whole lot has changed, except we've gotten a little bit more aggressive. So very complex morphologies have slowly been moving into the yellow zone. But if the green zone is the classic Everest criteria, then the yellow is kind of everything that's outside of that, except for the red, which is really should not be done. And so this is the take on the red zone by the Heart Valve Collaboratory, which is multiple stakeholders, including the FDA, getting together and trying to figure out what might be the red, yellow, and green zones. And the red zone right now is being defined as severe mitral annular calcification with a small orifice, less than 3.5 centimeters, very extreme, complicated leaflet morphology with severe tethering and large gaps, and then the inability to use either TEE or to access via the transeptal, using a transeptal crossing. And so this is a patient with an interrupted IVC that we wanted to do a mitral clip on, but obviously was unable to get the device up. And the other factors are obviously whether or not these patients have futility as far as their clinical factors and ability to survive more than 1 year. Green zone is the same, and yellow zone is roughly the same as the German criteria, obviously with a number of caveats and a number of parameters that will change based on the fact that we're now advancing with our devices. So Pascal has just been approved. And is indeed a device that we just used last week in 2 cases. It's a nitinol-based device. The differences are that they've got the frictional elements along the top of the wide paddles. There is a spacer in between in order to bridge very large gaps, but not cause too much stress on the leaflets. It is able to elongate, and get itself out of chordal entanglement. And then it has passive closure instead of an active spring closure of the mitral clip, with release from the atrial side instead of release from the ventricular side. So a lot of differences technically. These are all advances felt to answer some of the issues of the original mitral clip device, but obviously both both devices are being iterated, and we now have 4 different devices from the MitraClip side that we may be able to use. And this was just a stab by Flint to look at the various criteria that might indicate preferable use of some of these devices. So these are all in flux. There's new devices, new imaging tools that may obviate some of these various contraindications or lesser indications. So again, echocardiography, the key here for anatomic definition of success. And so these are some of the examples of those patients that might have great success. So P2 flail is ideal. Remembering again that P2 flails are a little bit more common in males, that women tend to have a little more of bileaflet disease and or anterior leaflet disease, which will reduce their chances, obviously, of getting optimal surgical results. So again, optimal is a P2 flail. And then you have commissural or anterior flail. You have a little bit of MAC. These are all less likely to have success. And these are some of the more difficult anatomies that might fall somewhere between the yellow and the red zones. But all of these receive the TEER device except for the perforation. And so when I look at what's green, yellow, and red, I'm really looking at it from the aspect of imaging. And that good imaging will mean that it's green, even if it's poorish anatomy. And that poor imaging moves it into red, even if you've got good anatomy. And so imaging is going to be really key in deciding whether or not you can do these devices. The other aspect of success is going to be what happens afterwards. What's the residual regurgitation? What's the residual valve area? We already have outcomes associated with mitral stenosis after these repairs. And so the review article that I referred to by Ben Shoshanto showed that the MVOA, mitral valve orifice area after the device of less than 1.9 is indeed a poor prognostic sign, and a vena contracta area of 25 millimeters squared, so more than 2 plus, is associated again with poor outcomes. And then finally, pressure gradients of over 4.4 in primary disease. In secondary disease, the gradient has is a lot more questionable as to what makes it prognostically significant, and that all has to do with low flow again. So again, for prognostic significance, mean gradient in primary disease of greater than 4.4 millimeters of mercury. So these are all defined by echocardiography. We now have guidelines that outline the assessment of the valves after various transcatheter devices, and this is just the chart for post-TEER device, and the various components that we look at to decide what our outcomes have been. Now, mitral valve is moving into other spheres. Obviously, this is degenerative mitral stenosis. And so in degenerative mitral stenosis, we're now using a lot of imaging in order to try and determine whether we can do mitral valve in MAC. And so valve in MAC scores, the MAC scores typically based on CT, but are now beginning to be better understood also on echocardiography. And so using advanced imaging, we can obviously determine whether or not there's a risk for not only embolization based on the calcium score, but also LV alpha tract obstruction. So the two big issues with valve and MAC, valve and valve, valve and ring are going to be embolization and LV alpha tract obstruction. So anchoring and LV alpha tract obstruction. And so toward that end, we've traditionally used CT in order, as you saw, in order to predict whether or not you'll have LV alpha tract obstruction. But now there are indeed three-dimensional echo software programs that will allow us to do the virtual valve implants on a moving image of the mitral valve. So these are all advances. So we'll move on to tricuspid valve procedural guidance, and this is where there's also been a lot of innovation. The innovation on the tricuspid side is a multi-level, although we're going to concentrate on intraprocedural imaging. But we've developed new classification schemes. We now have new nomenclature for the tricuspid valve morphologies. We have novel ways of quantifying, and obviously novel ways of approaching imaging. But the new guidelines for transesophageal echo pre-procedural imaging for structural valve disease was just published in January. Please don't print it out. It's 76 pages, but I do recommend highly that you go online and take a look at it. It's really full of images of figures and tables, and the tables with figures, and it allows you hopefully to understand better what interventional imager's job is as far as pre-procedural planning. And so for the tricuspid valve, we added the deep esophageal view because the tricuspid valve obviously sits very close to the diaphragm, and therefore the closer you get down to toward the diaphragm, then the closer you are to the tricuspid valve. So this is deep esophageal view, no left heart now in view, and we are able to then avoid the acoustic shadowing of much of the left heart structures or prostheses. This is just, again, one of the tables also available in the guideline showing you the different levels of imaging for tricuspid valve. And one of the more important views is going to be the transgastric imaging level. So transgastric, deep transgastric, and then obviously 3D reconstruction from any level is going to be really important in order to do the procedures. We've learned a lot from that transgastric view. This is all based on TEE, that there's 3 leaflets in only 54% of patients, and the rest have a combination of 2 to greater than 4. And the most common being 2 posterior leaflets. Very, very common to see 2 posterior leaflets. And so if you look at it kind of sideways, it kind of looks like a mitral valve with 3 different scallops. But this is a really, really common morphology of the tricuspid valve. And it does indeed affect the way that we do our transcatheter edge-to-edge repair devices. In addition, we've designed new ways of quantifying tricuspid regurgitation. We've discovered that the patients presenting to us have way more than severe disease. They have severe times 3 and times 4. And so we've extended the grading scheme as well as extended the ways that we have of quantifying. And these are all works in progress, but obviously this is an example of intraprocedural pre-procedural quantification of disease severity based on average vena contracta widths, the proximal ice velocity surface area, quantitative Doppler, and 3D vena contracta area. So we're using all of them. This is what the landscape of the transcatheter tricuspid valve world looks like. This is old. I mean, I could only fit so much on this slide. So there's a lot more devices than this, but the ones to remember are the ones that already have commercial approval in Europe. And those are going to be the TriClip, the Pascal, the Tric valve, which is a heterotopic valve replacement device, and the Cardioband device. Those all have been used in Europe now for at least a couple of years. And then the ones in the United States that are in randomized control trials, the only randomized trials to medical therapy that have been performed are currently being enrolled now and started in the United States. There are European arms of those studies, but the trials themselves were started in the US. So if we start with looking at transcatheter leaflet coaptation devices, and again, the ones that we have are the TriClip and the Pascal. The Pascal is the same device, same delivery system as the one for the mitral side. The TriClip has a different delivery system. Again, different controls in order to get down to the level of the leaflet and get coaxial with the coaptation zone. And so a little bit different for the 2 devices. And some of the limitations, anatomic limitations, have been described by this beautiful review by Fabian Pra. This comes out of the out of the PCR working group for tricuspid valve disease, which they've involved a number of us from the US as well. And so you can see that this chart is in that manuscript showing favorable, feasible, and unfavorable anatomy. Obviously unfavorable, including very large gaps, rheumatic type disease, which you can see, this is a patient with carcinoid, so terribly tethered leaflets that are immobile. Dense cords are very hard to get around with complex morphology. So the more complex the morphology, the more cordae there are, and so the more difficult they are to implant the TEER devices. And then obviously those patients with pacemaker-induced tricuspid regurgitation tend not to be able to have successful TEER devices. Despite some of these anatomic difficulties, the trials have been very successful. So they've succeeded in typically in over 80% of patients to get the 1 grade at least reduction of tricuspid regurgitation, and in that setting have shown significant improvements in quality of life and function. And so in 2020, Abbott announced that the TriClip received the CE mark in Europe. Now, right on the heels of the TriClip was the Pascal device with the CLASP TR trial. And in this trial, the same thing, a significant reduction in tricuspid regurgitation, huge numbers got at least 1 grade reduction, and significant over 70% got down to moderate or less. And in that setting, marked improvement in New York Heart Association class 6-minute walk distance and the KCCQ scores. And so Edwards announced soon afterward, after the TriClip was approved, that indeed the Pascal had been approved for treating tricuspid valve regurgitation. So 2 devices very rapidly approved in Europe and being used as we speak. And the difficulties remain. The leaflet and chordal variability has not changed. It is still difficult to maneuver through dense chordae and pacemakers. Indeed, the one other aspect of TEER devices is imaging. And toward that end, the ultrasound companies have done us a huge favor by really iterating their software that's available to us. And so we now have numerous new tools for interventional imaging. So this is orthogonal imaging with a user-defined orthogonal tilt plane. And so we no longer have to be at 90 degrees. We can tilt it to any degree in order to see the device arms equally, both the grasping the septal and, in this case, the anterior leaflet. And then we also have multiplanar reconstruction. So this is 2-dimensional biplane, which is a 3-dimensional function. You have to have a 3D probe for this. And then you actually have 3D volume reconstruction. And this allows us to position the imaging the same way every single case, no matter where we've acquired that imaging plane from. And that allows the communication between the interventionalist and the imager to be much more smooth and efficient, and has actually reduced the time for the procedures. The other thing that we have used is echo fluoral fusion. There's also CT echo fusion, CT fluoral fusion. All of those things are an attempt to improve the communication, obviously, within the procedure itself, and allow the interventionalist to really see the positioning of their devices based on where the structures are. So this is right atrium, right ventricle, RV outflow tract. This has all been co-registered based on the echo, which means that if they change the imaging plane, that the image will also move. And so this is all real-time imaging of the 3-dimensional structures projected onto the fluoroscopic screen. And one of the other significant changes has been 3D ICE. So this is a phased array probe that's been developed. So we used to have just a halo or a circular array probe, and now we have phased array. Phased array is a much higher image quality. You can see the line density, frame rates are very, very good. The functionality is going to be the same as a transesophageal image. So this is biplane images from the ICE probe during a transcatheter tricuspid valve intervention. And so you can see, again, we use TEE and ICE at the same time. So this is TEE, which gives us a bigger field of view, but then the ICE image allows us to really see the leaflets going into the device arms and have extra certainty that we're not going to have a detachment of the device. So this was one where there was inadequate reduction based on the ICE image, and so we went ahead and repositioned using the transesophageal view, and then got a great result at the end. So moving on to the annular devices. Now, 2 of these are not moving forward. The Cardioband and a number of other devices are indeed moving forward. And so the Cardioband device is an annuloplasty device. It's trying to mimic the surgical annuloplasty device. And in order to get that in, you really have to have CT planning. So this is the TEER devices don't need a CT. but annular devices and orthotopic and heterotopic valve devices are all going to need CT imaging to ensure anatomic appropriateness of the device. We have to remember that with the annular devices, we already know from surgery, because it's the surgical predicate is the annuloplasty device, that there are a number of predictors of failure, of recurrence of disease. And so the morphologic predictors are the size of the annulus, the amount of leaflet tethering, the amount of RV dilatation and dysfunction. There are lots of clinical predictors and surgical predictors. And so we have to be really aware of the fact that we know already, based on surgical annuloplasty, what probably is an inappropriate patient for the annular device. And so one of those is this marked tethering of the leaflets with RV dilatation. The papillary muscles have been pulled out toward the apex, which is why the leaflets are tethered. Those are patients that an annuloplasty device alone is probably not going to be sufficient. We need to be able to maneuver smoothly around, 75, 80% of the annulus. And so the angle of approach becomes important and has to be assessed also. And then obviously those patients that have primary disease or pacemaker related disease are not going to be at all candidates for an annuloplasty device. And so the early feasibility study of the tri-repair study of the Cardioband system, again, showed tremendous reduction in septolateral annular dimensions. This is what you want to see. Because as you reduce the septolateral and you bring in the anterior and the posterior leaflets toward the septal leaflet, you are indeed going to reduce tricuspid regurgitation. And as you see here, even out to 2 years, this device has shown efficacy and durability with safety, with great safety. And so this is a device, again, that was approved for in 2018. This was a 2-year result of that early feasibility, but early on, they got CE mark for the Cardioband device in Europe. And the problems are many. The annulus itself is really hard to see all the way around. It's not got a lot of fibrous tissue, and so it's the frequent dehiscences have been seen not only for surgical annuloplasty devices, but also for obviously the transcatheter devices. And then this is a patient that had the early feasibility Cardioband device, and you can see that the patient had a lot of tethering, and that's just not a valve that's going to see a lot of efficacy. And so we already know that there is a definite anatomic restrictions to the use of the annuloplasty device. Now, one of the problems that I mentioned was the lack of fibrous tissue in the annulus. And so innovation around new devices centers around some of the issues that we've already described for some of the from the prior devices. And so this is the device that creates its own fibrous annulus. And so by implanting this ring in the annulus and then waiting 3 months to allow it to fibrose in, and then exteriorizing the contraction device. So this is just a basically a string, then they can then pull and reduce the annulus after fibrosis has taken place. So lots of innovation in this space. In addition, because we've been seeing so many patients with massive amounts of regurgitation and very, very large gaps, very, very large annuli, there are a lot of novel devices that are using spacers in order to just reduce the amount of regurgitant orifice. The Cree valves, the Cormets, all of those have been already put into humans and are going to rapidly progress to trials. But the one that I think has the one type of device that's seeing a lot of action is the transcatheter orthotopic replacement devices. And so these are devices, again, that require a lot of CT planning. It's really behooves you to make sure that you have the right access and that you have the right approach and the right annular size. And the unfavorable anatomy is really limited to annular dilatation. So you need to have these super big devices, but just presented at London Valve was the Lux device, which is able to be put into annular dimensions as big as 60 and I think up to 70 millimeters, which is tremendously large. And then severe right ventricular dysfunction. So we know from from just modeling and from looking at PV loops of the right ventricle, that if you take away all tricuspid regurgitation and you increase the afterload, because you've now reduced the pop-off valve of the tricuspid regurgitation, that the mechanical dysfunction of the RV that has to exist but isn't seen because of the tricuspid regurgitation now is unmasked. And so this is a classic case of a transcatheter tricuspid valve replacement device, and you can see acutely what happens to the RV free wall strain. It cuts into more than half typically. And so it's important for us to understand, we don't really know yet what the cutoffs might be, but understand that the worse the RV function, then the more likely that those patients will have a significant dysfunction after complete resolution or elimination of their tricuspid regurgitation. We also use advanced imaging, so this is multiplanar reconstruction, to put these valves in. This happens to be the Evoke device. This is a compassionate use device patient. These are now in trials as well. And to place the 9 anchors underneath the leaflets and at the level of the annulus, you need to have multiplanar reconstruction. And so using advanced imaging, including occasionally the echofloral fusion, then we are indeed able to place these devices quite accurately within the annulus. The early feasibility trial, again, very successful. The safety profile is tremendous. The main problem that's been reported more recently has been bleeding complications because of the need for anticoagulation of these devices. And then again, the pacing rate. So it's somewhere now around 13% new pacemaker rates because again of the anchoring of this device. There are other devices that don't put a lot of pressure on the conduction system, and so will indeed have the hope of reducing the pacemaker rates. But again, annular size is going to determine feasibility depending on the device. The right ventricular function will also determine feasibility of the devices. Conduction disturbances, pre-existing pacemakers are not a problem, but the risk for new pacemakers is real. And then finally, because it's a very low pressure side, the problem is generation of thrombus on that low pressure side, and these patients really require anticoagulation. A lot of innovation going on with the devices. I mentioned that the Lux valve was just presented, 176 patients already implanted, and with very, very high success rate and low pacemaker rates of about 1%. So this is going to be a device to look out for. And the proposed algorithm, perhaps for device choice, is a little bit complicated, but I think it's even more complicated than that. This is what I see the device choice being. I mean, it's just looking at everything related to the patient anatomically, but also clinically. And so we are going to have to be very thoughtful about where we go with these devices. And I'm gonna stop and not really talk much more, but to say that simulation and all sorts of other imaging advances like holography are going to play some role in the training of physicians and the way that we think about how to image the procedures. And so it's a really fun space at this point, and with a lot of advances that are rapidly moving forward. Thanks for your attention.
Thanks so much, Dr. Hahn. That was a great talk. And if anyone has questions from the audience, please just leave it in the chat so that we can call on you, or feel free to raise your hand. We have a couple of questions. I'll start off with asking one of my own questions, and it's a question just about radiation exposure during structural cases, especially to the imager. Yeah. There was a study that came out this summer in one of the JAMA subjournals, and it was a single site center in Michigan, but they had shown that the imager had gotten 5 times the amount of radiation exposure compared to the structural interventionalists. Yeah. And so I'm just wondering, what do you think about radiation exposure in these cases to the imager? And are there any specific measures that you all are trying to take to minimize that exposure?
Yeah, I mean, I think the recent document reviewing radiation exposure for pregnant interventionalists is what it really outlined really nicely, actually reviewed all the documents, both from Europe and the United States, showing the limits of radiation exposure that you're looking for, with the US being a little bit higher than the acceptable levels than they are in Europe. But if using lead, and there are lots of studies that have already looked at using the floor to ceiling rolling lead shields. Those are very, very effective in reducing the radiation. And then the way that we stand, we're able to use the length of the probe to keep distance. As you know, distance is a huge reduction in radiation. We're able to keep a fair amount of distance between us and the collimator. And then the other thing is whenever we're manipulating the probe, they stop flowing. So if we have to actually go in and go under and go into the field of radiation, they stop flowing. And so it's an education of the interventionalist, really, to understand that obviously we're part of the team, and they certainly don't want to do anything to hurt us, I hope. And so it's that kind of preparation. When we built our new lab, we have a new lab that has the echo fluorofusion and the holography and everything. That lab was designed to have lead shielding mounted on the table on both sides, so that because we're standing we're standing on the left side of the patient, we also have lead shielding that covers the bottom, and so all of those things are just a testament, at least to my team's awareness of the risk for the imager. So it is a real risk, but obviously there are many things that we can do to reduce that risk.
Great, thank you. Dr. Almaria, did you want to unmute to ask your question?
Yes. Hi, Becky.
Hey,
it's good
Stanley.
to see you.
Good
Absolutely.
to see you.
Fantastic talk and impressive tour de force to nicely summarize essentially the entire transcatheter valve space. Just really did appreciate the talk. Have many potential questions, but maybe I'll focus on one that I've been involved with recently, and want to get your thoughts on. So as you highlighted, the undertreatment of symptomatic severe aortic stenosis, and as you know, looked at this at my prior institution and found treatment rates that were dismally in the 50% range, and even for the low gradient population, rates as low as perhaps only a third of patients getting treated. And when you dive into some of this data, it suggests that in some of these patients, aortic stenosis is not even recognized. So, these patients may not have cardiologists, they are not referred to cardiologists. And I find it, and I suspect that very frequently providers may not know what to do with the metrics that are reported on echo reports. And so I want to get your thoughts in terms of whether there needs to be a paradigm shift, one that mirrors what's done on the radiology side with incidental findings, where there are very specific suggestions for how that nodule, lung nodule, for example, may be managed and serially followed. And do you think it's reasonable for the echo community to kind of pursue similar approaches, and one explicitly stating that this may be severe aortic stenosis, for example, when there's low gradient, to outline some of the subsequent diagnostic testing that's needed, and maybe if you take this to the extreme, even consider suggesting referral to heart valve teams, since it is a class 1 indication?
Yeah, I mean, obviously, as always, you have to be a little careful what you put onto a report, right? And so that's going to be the main kicker for everyone, not to force someone's hand, based on some possible finding. But I am 100% behind you in that there's a few things that we as echocardiographers can do. One is to embrace artificial intelligence, because we are able to early on, this is like 5-6 years ago, I was able to see one program that could basically tell you pretty well whether or not you had aortic stenosis from a single short axis view of the aortic valve. And we do that clinically. So those of us that do a lot of aortic stenosis, we can tell you by the first short axis view at the tips of the leaflets that what the valve area is going to be. And frankly, in my lab, 80% of the time we're able to planimeter that valve area and I ask all of my readers to planimeter first, and then we'll figure out if you were right by the continuity equation. And we are right. Literally, the correlation is very, very high. And so we should be able to use AI in order to help the readers, the echocardiographers, appropriately read and not rely just on gradient. It would be great if they could also automate valve area calculations, because I think so frequently we're just getting a gradient, and we're not even getting a mean gradient. We're just getting peak velocity and peak gradients. And so I think that there's a lot to be done with education of the echocardiographer, but also the use of AI algorithms. And this is also where the ultrasound companies can help us. But the other area that I find extraordinarily interesting is to use an even simpler tool, which is the EKG. So numerous studies now have shown that you can, based on thousands and thousands of EKGs, that you can with some accuracy determine, and it happens to be somewhere on the T wave, that it's determining aortic stenosis, believe it or not, but with some accuracy determine that you've got significant aortic stenosis on EKG. And so these are things that can be, now you're talking about getting out to the internist, getting out to areas that don't even have echo, but have at least an EKG machine in order to be able to diagnose aortic stenosis and bring those patients forward. But I'm with you 100%. It's fascinating work.
No, thank you, Becca. I mean, it really is. And I would, the reason I raised the question is because I think, the radiology community has kind of pursued a very different approach. I think because honestly, they were legally liable to missing nodules. And it's interesting that the echo community has a very different perspective on, being concerned about overly dictating and perhaps self-referring. And I certainly understand that concern, but agree with you that relying on technology may be the way to go.
Yeah.
And unfortunately, all the data we have is what happens after the echo. What we don't know is what you're starting to allude to, is that there may be a tremendous fraction of patients that don't even get an echo who die with untreated valvular heart disease. And I think that's the next phase that we have to tackle together.
Yeah, I think so too. You must wonder the same thing, but we've been doing this for a very long time and our volume has not dropped. If anything, it continues to go up. And so, it just goes to show you how undertreated the disease was. If we're still and we have more sites doing it, every site is doing more. It's a tremendous patient population that's being missed.
Thank you, Dr. Amari, for that question. Dr. Tolstrup, you had a few questions as well.
Yeah, thank you. This was a wonderful talk. I really, really appreciate it. My questions are related to programmatic, a couple of questions there. And first of all, do you feel that every patient considered for advanced valve therapy should be seen by a multidisciplinary team? And how do you incorporate your heart failure experts into the valve team? Are they part of the team, or they kind of parallel with some referrals? That is my one question. The other one is, with the growth and for interventional echocardiology, we don't really have good competency sort of criteria, and we also have problems in many places about reimbursement. What are your views on the future for these things?
Yeah, these are really good questions. All right, so the first one is the multidisciplinary heart team. There's certain patients that come in to the valve center that clearly have been, we believe, optimally medically managed, or in aortic stenosis, it's a little, it's really a mechanical disease. So it's not like there's a lot of therapy. It's really the mitral regurgitation and tricuspid regurgitation patients that we will sometimes refer those back to our heart failure experts. We learned early on through the COAP trial that we needed to have the heart failure team on board. And that's the consensus document from 2020 very clearly added they weren't on there before, but they added the heart failure expert as part of the multidisciplinary team. And so we have a weekly meeting with heart failure on Mondays, it turns out, in the evening. where we will discuss patients that have been going both ways. So either patients we referred to heart failure referred to us, and what we're going to do, and we make a plan for those patients. So they are definitely part of the multidisciplinary team. We have a larger valve center meeting where the heart failure people could not come. It's always on a Wednesday morning, and it was just more convenient for them to do it on Monday. So, but that's where we have, surgeon, all imagers and all interventionalists together discussing all the other cases, and where we'll relay what heart failure has told us from the Monday meeting. But they are heavily involved now with particularly our regurgitant lesions, so AR, MR, and TR, less so for aortic stenosis, and I think it's really important. As far as training for the imager, obviously it's a brand new field, right? I mean, I was probably the only one in 2009, and it's grown very, very rapidly since then. And so the ACC and the ASE both recognize that, and the training statement out of the ASE is almost finalized and will be coming out soon. I think it's going to be submitted probably before the end of the year to the board for approval. And then the ACC is generating an advanced training statement for the multimodality imager, which structural imagers tend to be. I'm old school, and so I train in echo, but we are constantly in our valve meetings doing correlative comparisons with other imaging modalities, mainly CT. But the ATS, the Advanced Training Statement, is under development. We hope to have it out by the beginning of 2024, but it's really, at least the echo part of it is pretty done, and so it's just it will be very different, this training statement, because it's really trying to define what a multimodality imager is and how much cross correlation there needs to be, and et cetera. So it's taking us a while. It took us almost 6 months to figure out what we were writing, and now we're in the writing phase of it. So it'll come out hopefully by the beginning of 2024. So there will be some guidance as to how many studies and how many studies to correlate, and what types of disease processes require what types of correlation, et cetera. And so it's a really going to be, I think, a really nice document. But we will have some guidance coming soon.
Great, thank you.
And then Dr. Ching, you had a question as well?
Yeah, Dr. Hahn, nice to meet you here. I've listened to your lectures for years at conferences and et cetera. It's always just so educational and so full of information. I love your pace. I do want to add on to that, the idea of, so I'm heart failure trained, both I'm structural trained. I think the large majority of patients we see in heart failure with mitral regurgitation, that mitral regurgitation gets better, right? We know that the NT generally shrinks the ventricle. If you look at COAC, the control arm, those patients, their ventricles continue to dilate. And so that's actually a small portion of our patient population.
Yes.
I did want to ask about RV function and tricuspid regurgitation. I guess two-part question. How do you think about repair versus replacement, in particular about RV function? There has been this idea on the left side that the mitral regurgitation of pop-up valve, I think that has been mostly disproven. Is that going to be the same lesson on the right side? The other question is whether or not PA pressure is high pressure TR, right, versus low pressure atrial TR.
Yeah.
How do you think about that disease entity, and how do you look for other etiologies, but also how do you think about that procedurally to support the RV?
Yeah, I mean, the tricuspid is just the most fascinating valve, right? And obviously, in order to know about the tricuspid, you have to learn about the right ventricle. So as far as pop-off valves, it's pretty clear, and we've modeled this on PV loops, on PV loop modeling, that the more you reduce the tricuspid regurgitation, the worse the RV is going to look, although that's probably intrinsic mechanical dysfunction that's already there from chronic volume overload as well as pressure overload, obviously, as you implied. And so is there some utility? Well, I don't know that it's proven on the right side, but what we've seen is that in those patients that we are putting in replacement devices, we were being in the compassionate use arm, we just put everybody in there, and including the ones that we thought had terrible looking RV function. And as I showed you, the RV function is going to go down. And so we thought for sure that some were going to have to end up on ECMO. And early on, we did have some deaths, and it's probably RV failure, et cetera. We've continued to have every now and then in the early feasibility arm, late deaths from RV failure. But in general, they've tolerated it pretty well. So, I'm not sure. And I'm also not sure what RV function parameter will predict that, because it does turn out that when we look at RV-PA coupling, and this gets to your question about pulmonary hypertension. So RV extraordinarily sensitive to pulmonary pressures, whether it's postcapillary or precapillary. Obviously, precapillary has the worst prognosis, but the postcapillaries aren't good either. And that's because the RV has to obviously eject the whole stroke volume into the lungs and the left atrium against a closed mitral valve. And so once you lose any compliance of any of those structures, then you're cooked as far as the RV is concerned. And so we believe, or I believe, that RV-PA coupling may be one of those key parameters that we look at to judge when the RV has gone beyond the Starling curve. And not able to compensate their contractility for the amount of pulmonary pressure. It turns out that in multiple different disease populations, that RV-PA coupling really is pretty predictive. The number that frequently comes out when you're using TAPSE over PASP, as fraught with error as those measurements are, the number of about 0.4 centimeters per millimeters of mercury continues to come around, whether it's pulmonary hypertension patients or the tricuspid regurg patients. And so we've looked at the TriValve registry, and the cutoff is 0.41 to predict outcomes, baseline RV-PA coupling, baseline, predicting outcomes after TTVR. And indeed, the ones that are able to drop their coupling gets worse. They have a better prognosis than the ones that don't go anywhere. They don't have any reserve. So contractile reserve, extraordinarily important in TTVR. And most of those TTVR patients in that particular trial were repair patients, not replacement. So we don't know yet about replacement per se. The RV has some amount of contractile reserve and ability to improve itself. So even with the ones that have poor function, once the follow-ups all seem to improve. And what the meta-analyses show with the TTVR patients is that they will, no question, have a drop in metrics of RV function. So TAPSE, FAC, fractional area change, all those seem to fall after you remove some or all tricuspid regurgitation, but the forward stroke volume goes up. And that's what you want. So your total stroke volume is going down, right? There's just no question, because you're taking away the tricuspid regurg. But as long as what's going forward goes up, then I think the outcomes will be quite good. We're still working on it. It's really to us still a relative black box, and looking at all sorts of different metrics. Including 40 flow. I mean, 40 flow can predict pulmonary hypertension. 40 flow can predict, prognosis in pulmonary hypertension. Those are things that may actually end up being quite predictive in other disease processes as well. So we're trying to look at everything, but the trials are. One of the trials has a CMR substudy, CT CMR substudy, and that's going to be very, very interesting.
Thanks so much for staying past the hour to answer these questions, Dr. Hahn. We have one last question. Dr. Delling, I think you raised your hand. Did you have a question to ask?
Yes. Hi, Becky. Great interacting with you again.
Yes.
Great talk. I have just a quick question about atrial functional TR and treatment of atrial fibrillation. And ideally, if you're treating atrial fibrillation, you're thinking perhaps the atrium will get smaller, less tethering, less TR. Are there situations where you still think about this, or you just give up and see a severely dilated atrium and just proceed with clip without attempting the cardioversion or AFib treatment first?
Yeah, I think treating, some of it depends on the duration of the atrial fibrillation in my mind. There's no question on that the data is already very, very clear about tricuspid regurgitation and atrial fibrillation, and that if you rhythm control, and this is 2 studies already, maybe 3 studies out there now, showing that if you control the rhythm compared to those patients who you did not control the rhythm on, the RV clearly remodels after conversion to sinus rhythm. The RV remodels, the tricuspid get the RA remodels, and the tricuspid regurgitation gets less. So data is building more and more and more. It's made it into both guidelines as both the European and the US guidelines as a consideration for treatment of tricuspid regurgitation is to control the rhythm. Now, how aggressively you control the rhythm, I mean, we've not, in patients who are chronic atrial fibrillation that have atria that are tremendous. I mean, you've seen them, right? They're like bigger than your head. It's like, where is it in the, how does it fit in there? Those are patients that have long-standing atrial fibrillation, highly unlikely to be able to convert them, although ablation is always a possibility as well, and quite aggressively being pursued in Europe, by the way. And I think that more study needs to be done on that type of rhythm control compared to just cardioversion. So I would say that if I had just gotten a new patient, we think that the atrial fibrillation is relatively new. I would try to convert. I mean, speak to your EP colleagues and see what their feeling is. And, sometimes I speak at the conferences and I say, listen, there's 2 things I can ask of our EP colleagues. One is, please don't put the pacemaker across, a leaflet, but kind of tuck it into the commissure so it doesn't cause regurgitation. And the second is to rhythm control all atrial fibrillation that they see before it gets to the point where we have to do something about the tricuspid valve. So it's a great question, and it's just really an area that's really ripe for further study.
Thank you.
All right, thanks so much again, Dr. Hahn, for such a fantastic talk. We're going to have a recording of this available on our division's YouTube page. And for everyone in the audience, I'm looking forward to seeing you next week. We're going to have Dr. Andrew Ambrosi from Kaiser San Francisco speak. Thanks so much again, everyone.
Okay.